Good afternoon, colleagues. Goedemiddag, collega's. Dumelang Batsabetsi. My name is Jeremy O'Kennedy. I thought I'd do this quick message to convey the exciting news that I'll be joining you at Morningside Mediclinic starting early November. I've got the high privilege of succeeding Dr. Gary Levy in his practice. Dr. Levy will be reuniting with his family in Israel.
Now, colleagues, rather than just do the customary introductions, I thought I'd take this opportunity to clear up some very common misconceptions about dermatology and what dermatologists actually do, and give you a very interesting and valuable guide-like overview of the uncommonly known things that we should actually be treating and should actually be referred to us. There's been lots of work over the years in the state, especially the academic setting, to improve referral pathways and ensure that we are actually seeing these patients. But that's less so in the private sector, I gather. So I want to encourage you to send these patients to us. So the first one on the list is the so-called primary immune deficiencies. So as you might know, this is a very large spectrum of syndrome and genetic diseases, and not commonly known that the dermatologist is actually at the center of suspecting and then making this diagnosis with the assistance then of geneticists and a referral from pediatricians. The reason for this is actually quite interesting, but also something that's easy to understand. I'll explain a bit of that on the next slide. The next one is the paraneoplastic syndromes and stigmata. As you know, there are many described syndromes that are associated with certain oncologic processes and diseases, and also stigmata, so subtle signs that can be a clue of an underlying malignancy. So the reason for these two, the primary immune deficiencies and the paraneoplastic syndromes, the reason that they should fall under the ambit of the dermatologist is actually quite easy to understand if one understands the principle. I often tell medical students that the skin is like a immediately readable roadmap, cheat guide to overall systemic health. So the immediate advantage is that the skin is immediately readable. So there's no extra tests or investigation that needs to be done to elicit what's going on. You can just use your eyes. And then the second very important factor is that we know that pathology starts on a genetic and then a cellular level. So it starts with one cell that becomes aberrant or diseased. Now, when that cell is not visible, so your internal framework of your patient, then it takes many cells to be affected for symptoms or biochemical or other evidence to develop, as those cells become diseased enough in their number to affect function. Now, this is not the case in the skin. You can have one or two cells that are diseased, not symptomatic, but visible because we can see the entire skin surface. And so, in essence, it is the earliest sign of internal pathology. And that's also why the skin is such a great crib sheet to all other areas of medicine. I also tell the students that if they want to do well in their oral exams, their clinical exams, know the skin as a cheat sheet. Because even if your patient has a cardiovascular or metabolic disease, There will be skin signs, and most of them will be early. So the reason that paraneoplastic syndromes and stigmata on primary immune deficiency should fall under the diagnostic ambit of the dermatologist is because the earliest signs of these conditions will show on the skin. Okay, then venereology. So some of you might know that dermatologists used to be called, and are still called in some European countries, dermatovenerologists. So all STIs still fall under the primary ambit of a dermatologist. So this includes the entire list of sexually transmitted diseases. So all STIs should actually be sent, referred, and treated by a dermatologist. Then drug reactions. So I think it's known that some drug reactions. So everybody likes to throw around the Stephen Johnson syndrome, which, by the way, is by far not the worst drug reaction we see. But actually, all drug reactions, um, whether there is marked cutaneous signs or not, uh, should, in a good academic clinical setting, involve a dermatologist assessment. Uh, on the one hand, because it's such a large part of our academic training, and also on the other hand, once again, the skin will always give you subtle signs of what's actually going on in the internal environment, and those signs are early. So the big thing with drug reactions is that you want to prevent permanent or long-standing disease or damage. And so the skin is going to be your earliest marker of that in many situations. Then, not commonly known at all, oral pathology. So physicians know well enough that dental pathology and some of the oral pathology are treated by our colleagues, the dentists. But actually, in the MBCHB setting, uh, oral pathology in terms of the oral mucosa, and this includes then other mucosal surfaces, so anal genital disease, even the ocular mucosa. Oral pathology should be going to the dermatologist. This includes oral mucosal surgery as well. In actual fact, our ENT colleagues, that scope of practice starts at the pharynx and the tonsillar pillars. So everything in front of that should actually involve a dermatologist. Then very interesting, so leprosy, mycobacterium other than tuberculosis, and all of the other so-called neglected tropical diseases. Uh, Leprosy in the minds of most of our colleagues is a disease that's dead, in South Africa, something that we've overcome. That's not the case at all. So I can tell you that we diagnose in the state sector, in the hotspots of our country, including where I did my training, diagnose a case at least once or twice a month. And leprosy is definitely a primary dermatological diagnosis, because all of the active leprosy disease signs, almost all of them are dermatological. And burnt out leprosy is something that you can do nothing about. So that's way too late. So unfortunately, we're still seeing all of these patients very late, but that includes all of your weird and wonderful tropical diseases. So travel and tropical medicine very much involves the dermatologist, because once again, these signs are signs that you're going to see in many of these diseases. And then to interpret what is seen, that's where the dermatologist training comes into. And then the vasculitides, so also not well known, that actually the entire ambit of vasculitis, so including all of your primary syndromes, your secondary vasculitides, all of your different cellular forms and associations, also very much a part of dermatology scope. And then ulcers, especially these patients that struggle with chronic, long-standing venous and stasis ulcers. Very important that they get referred to us. In the state academic clinic that I worked, we healed all of these ulcers. So some of them take longer, to 6 months, but typical story: patient has deep circumferential ulcers for 15 years or more, and is at wit's end, and then the referral to us finally comes, and 6 months later the ulcers are healed. And then the porphyrias and nutritional diseases. So once again, uh, things that you might not be seeing commonly anymore, like scurvy, your different forms of porphyria is actually a very complex disease. Some of you might know the classification of porphyria is not that easy, but these diseases we do still see, and unfortunately they're very commonly missed, and diagnosis is way too late, where end organ damage has already happened, is often permanent. So these patients need to be referred. Um, Interesting signs of poisoning and drug abuse. So if you think about it, both of these entities, it makes a lot of sense that the signs that this is happening is something that one sees. And I also often tell the students, if you wonder if it's dermatology or not, if you can see it, then it probably is. And then your autoimmune and heritable or inherited connective tissue diseases, which includes the entire connective tissue surface, not just collagen. Um, these are also all fall under the ambit of dermatology, often in association with our physician colleagues, rheumatologists, nephrologists, etc. But definitely we need to be involved as well. And the early signs, once again, often dermatological. Then, not commonly known histopathology. So we actually have to pass pathology in such a way that we are able to read our own pathology. So that's also why one of the fellowships in dermatology is dermatopathology, which then has the qualified dermatopathologist who was a dermatologist, then work full time in a pathology lab and sign off and report on all the dermatopathology. So uh, we are well trained, well versed in the microscopic and histologic pathology itself, and that sort of leads to the second thing I put there in brackets. That means because we have an understanding, uh, quite detailed understanding of the histopathology where diagnosis lies. So in medical absolutes, we don't have any, but the closest we get to that is the fact that diagnosis comes down to histopathology, because as we mentioned earlier, the pathology starts at the cellular level. That means that we are the specialists when it comes to taking biopsies. The reason for this is it's such a fine line between having a representative sample and not. And that means that the person doing the biopsy understands a few things very well. The first one, what is the pathology that he's seeing on a macro level? Meaning, is there necrosis going on that I want to not include in my biopsy because it's not going to aid in what I am suspecting? And that leads to the second thing, what am I suspecting? Because then your area that you're going to biopsy differs drastically in terms of what you're actually suspecting. Otherwise, you're going to have a non-representative sample. And it's a very sad thing that diagnosis is delayed often in malignancies as well for many years because incorrect biopsy has been done. Then cutaneous, tricho, nail and mucosal, and oncosurgery. So all of these different areas in terms of the organal anatomy fall under the ambit of the dermatologist and the surgery as well. And this is becoming more and more and more so in the rest of the developed world, where these boundaries of practice are being well defined, and we work very well with our general and plastic surgery colleagues, and I look forward to doing that as well. And then something that especially our plastic surgery and oncology colleagues colleagues might know, Mohs micrographic surgery is one of the most exciting areas of development in dermatology in the last 30 years. Basically a field of surgery pioneered by Frederick Mohs, which sort of does exactly what we've been wanting to do for many years and everybody sort of knew was the better way. That when it comes to oncologic surgery, rather than cutting according to predefined parameters according to the histologic diagnosis, cut histologically in an active and dynamic way, meaning cut small sections and cut until there's histologic clearance. So the dermatologist who, as I mentioned, is trained in histopathology, then receives extra training in Mohs micrographic surgery, and then these histopathology examinations are done by the dermatologist in theatre whilst he's cutting, which equals two things. On the one hand, a very much more cosmetic result in most of her cases, and then a much lower recurrence rate of the indicated malignancies, because you are ensuring that on a cellular level you have clearance throughout all levels and diameters, edges of your incision. And this is something that was pioneered by Dr. Peter du Plessis, who you might know in South Africa, and he's got the very large Mohs micrographic surgery unit in Silver Lakes in Pretoria. Thank you very much for the opportunity, colleagues, and I really look forward to an excellent working and also friendship relationship with all of you. Here are my details. As mentioned before, I will be succeeding Dr. Gary Levy. It's a big privilege, and so the practice suite and the number there will stay the same. Thank you and have a great day.